Hello, everybody. Welcome to CalCare office hours. We are so excited to have you guys here and our guest today. My name is Erica Ferriston, she, her. I am the Director of Healthcare for All Los Angeles, along with Maureen Cruz and our co-chairs Bronwyn Major, Changsim Lim, and Gina Harris. Healthcare for All Los Angeles is a local chapter of Healthcare for All California. A statewide Los Angeles is a local. Are we good? I heard some feedback there.
Sorry about that. I just had to mute.
Okay, so yes, so I was saying we are a local chapter of Healthcare for All California, which is a statewide, nonprofit, nonpartisan, all volunteer organization. Our mission is to achieve a universal healthcare system through single payer public financing, with the goal that all California residents have comprehensive, high quality health care. And thanks to the California Nurses Association, California has a single payer or a Medicare for All bill, a statewide bill, Assembly Bill 1400, the California Guaranteed Healthcare for All Act, also known as CalCare. So before we get started, we're going to do our land acknowledgement. This is one that we have borrowed with permission from White People for Black Lives. And so Healthcare for All Los Angeles acknowledges the Tongva and Kizh peoples as the traditional caretakers of the land we currently reside on. That is the Los Angeles Basin and Southern Channel Islands. We seek to honor the land and the courageous people who have been its stewards, modeling a tradition of resistance seeking liberation. We pay our respects to ancestors, elders, and relations past, present, and emerging. And if you are outside the greater Los Angeles area, you can find out whose land you are on at native-land.ca. And so, we are here talking about CalCare, and we have a wonderful moderator, C. C, I think I'm gonna just open us up a little bit with putting up the CalCare principles and then maybe kicking it over to you. Does that work for you, C?
Sounds perfect.
Okay, that sounds great. So what is AB 1400? The California Guaranteed Healthcare for All Act, also known as CalCare, is the solution to our broken white supremacist capitalist healthcare system. It will guarantee healthcare as a human right in the state of California, and it will end the current healthcare caste system. It will provide comprehensive, high quality health care to all, and all means all, just like Medicare would do nationally. But this is just focused on the state. So the 7 principles are universal coverage, everybody in, nobody out. Everybody, regardless of race, gender, gender identification, country of origin, disability status, immigration status, marital status, age, income level, employment status. Everyone gets the care they need regardless of the ability to pay. It is a single payer public program. It is publicly funded through progressive taxation to cover all the necessary care in California, eliminating billions in bloat and waste and saving people thousands of their health care. 1 second, technical issue. Okay, great. It is fully comprehensive benefits. This includes medical, dental, hearing, vision, mental health, prescription drugs, long-term care, and more. All decisions about care would be made between the patient and the provider, not the insurance companies. Freedom to choose your care provider. Under CalCare, there would be no more in-network or out-of-network. You would have the freedom to choose any doctor or hospital you'd like. Free at the point of service. No more copays, premiums, or deductibles. You arrive at the doctor's office, show them your CalCare card, and get the care you need. Just transition. Funding and programs to protect and support any displaced workers in the insurance industry, and patient care based on patient need. No more financial incentive to avoid providing necessary care, including value-based payment models for providers. And so with that, I will turn it over to C.
Welcome, everyone. Thank you, Erica, for that. That was amazing. I'm C. I use they, them pronouns. I am a non-binary person in this world. This is just going to be a informal kind of talk. So that's a little bit about me. So I'd like to open it up and I would like to invite the speakers who would like to share a little bit about themselves, what their pronouns are, and maybe what their favorite winter tradition is, just to bring some humanity into it, and anything you would like to share about your experience with healthcare and the intersection of your queerness. Who would like to get us started? Go for it, Daniel.
All right. Hello, everyone. My name is Daniel Wilson. He, him pronouns, trans male, trans masculine. So a little bit about me. I live in Port Hueneme in Ventura County, East Coast, born and raised. The Navy moved me out here in 2009. I got off the plane in November and it was 70 degrees. And I said, I'm never going back. So, and I have not. I've been here ever since. Ventura County has absolutely become my home, my community, and I love it here. Currently running for state assembly to fight to get us CalCare and a lot of other wonderful protections and support that we need. Here tonight to talk about my experience going through our California healthcare system, transitioning, and the wonderful benefits that CalCare can provide to not only my community, but every community at large. So thank you so much for having me.
Thank you, Daniel.
Okay, I guess I'll go. Hi, everyone. My name is Tsukuru Fors. I'm representing, well, I am a pronouns he, him. I'm a trans male. Just actually started transition in July of this year. Very, very new. Yes, thank you. And I'm also California Red Berets, which supports both Medicare for all at federal level and state initiatives. So I'm here, representing Red Beret as well. But really, thank you so much for inviting me. I was invited at the last minute, and I am very, very honored to be here. And I just really, what I can offer is really like my personal perspectives and personal insights, going through transition and actually kind of mentally preparing for transition, and how, what kind of difficulties, reservations that I had about the process, given the current healthcare as it is. Okay, so winter tradition. I'm originally from Japan, although I've been here for 31 years, so that's a long time. But I guess still the winter tradition that I really love, but I don't get to participating anymore, is so on the New Year Day, or actually New Year's Eve, more like, in Japanese household, we always pound rice to make mochi. So that's like a really like old tradition, and like, a lot of like family members participate in. So I love that, but I don't get to participate in that anymore. So anyway, yeah, thank you.
Thank you. See, anybody else like to share? And we might have some more speakers come in as they log in. Okay, beautiful. Daniel, would you like to get us started? I heard you would like to speak, and I want to be respectful of your time.
Sure, I'm fine with that if everybody else is okay. I don't want to jump ahead of anything. No, good, okay. What I would like to say is that, I was in an interesting predicament when I started transitioning in 2015. Like a lot of us that decided to start transitioning, I didn't know anybody that was transgender or where to go, how to get started. Fortunately, my wife at the time knew somebody that worked at her old job, and she connected me with him, and he pointed me towards the Santa Paula Pride Clinic in Santa Paula, and then also a really wonderful therapist in Ventura. And I was broke at the time, still kind of, but different story. But so I actually qualified for Medi-Cal, and I was really nervous at first because I had heard a lot of awful things about Medi-Cal, Medicare, Obamacare, for whatever reason, whatever insurance it is, problems getting to your treatment, delays, holdups, all these red tape that you have to jump through. And I have been pleasantly surprised with my experience. And I've been told that mine is incredibly unique. I don't know if I got in at the right time when things were getting a little better. Maybe some people had prior experience, because I know the Pride Clinic had just opened in Santa Paula in 2015. I was one of the first, not couple patients, but they were still really learning what was going on. So I had a really great experience. Medi-Cal itself, it covered all of my therapy, it covered all of my doctor's appointments, it covered all of my surgeries. And so because I was fortunate enough to have those benefits, I know how not having those and having even just access to counseling, let alone if we decide to physically transition to affirm our gender, that those are, people take out GoFundMes, pay out of pocket, go to unscrupulous providers that may take advantage of us and exploit the situation. And so it's not only life and death for our mental health to be able to access this care, but in the way that we are treated in the medical profession, whether we have the protections of insurance and guaranteed payment, and then also how we're treated in society. If it takes us longer to transition because we're saving up money for years, it can put us in a weird limbo state as well, where mentally we're not happy because we're not all the way there yet, and also physically, we, especially with the bathroom debate and everything like that, there's a lot of reasons that finances and access to healthcare shouldn't be a barrier to what we can get access to affirm our true self. And so even though my situation was apparently unique thus far and not entirely rare, but not the norm, I am fighting to make sure that that is the norm for everybody, not just transgender folks, but working class people, our immigrant population who is paying taxes and doesn't have access to any of our benefits and resources. And that's one of my favorite things about CalCare, is that there are no limits as far as, or restrictions or red tape. Every category of person is covered if you are a resident of California, and that is exactly what we need. And CA leads the way. If we do this here in California, we can push stronger for whole Washington, for the New York single payer. That's how Canada got it passed. It was not an initial national bill. They went province by province, and slowly the country turned. And once we have it here, people are going to be crossing state lines. We're going to show how much money our communities save, how much money our government saves in providing benefits to its employees. Small businesses are going to flourish and grow. And we're just going to show them not only is it possible, but how much we will thrive as a society and as a state. And they're going to be clamoring for it by the time we're done. So thank you all so much for having me here. I don't have to hop off just yet, so I'm really excited to stay and hear some more stories.
Can I just jump in here for a minute, C? Daniel, oh my gosh. So happy you're on here. So thrilled that you're running for office. If our elected officials were like you, healthcare would be a human right. So, and you get it, and you're fighting for it, and you're a fighter. And I'm just wanted to express my gratitude to you. And I also wanted to say, please maybe drop in the link, where you're running or your website. And then Paul Newman, if you want to raise your hand, Paul, he's our webmaster and our tech guy. He'll also post that in the Facebook link or the Facebook chat so that everybody can see that. So just wanted to say that. And with that, and thank you so much for being here and sharing. I will turn it back to C.
Sure. Just real quick, I'll throw out. So the current district, the numbers have come out with the new lines. So I'm going to be AD 38. And so it's the western portion of Ventura County. So it kind of cuts off north of Moore Park, Thousand Oaks area. And so Ventura, Camarillo, the north half of Camarillo, Oxnard, Port Winnie, Santa Paula, Fillmore, Ojai is basically the district. I'll put the links and everything still in the chat as you're asked, but I did forget to say that. So thank you for giving me that opportunity.
Thank you so much, Daniel. And it was really, thank you for sharing your story with us. It's always nice to get our stories out there. Would you like to go next, Tsukuru?
You mean me?
Yes, sorry.
That's
Could you say your name one more? No, it's important.
Yeah, Tsukuru.
One more time. Tsukuru.
Tsukuru. Yeah. Perfect. Beautiful. Thank you.
Thank you. Sorry.
Yeah, so no, not at all. So before I jump in, actually, I wanted to acknowledge, hi, Daniel. We communicated through Twitter a couple of times, but I'm just like so excited to see you. And I echo Erica, so glad that you're running. I think, somebody like you, if elected, will make a big difference. And thank you so much. So, yeah, I was actually quite nervous. Delighted, but nervous when I was invited. And because I wanted my talk to be beneficial and kind of really, make it an opportunity for us to think about, what are the opportunities in, passing AB 1400. So I kind of did a little bit of research because I'm a former researcher before I was, before I became unemployed. But as I said before, I will speak from my own personal thoughts because I'm in no way an expert. But I could tell you what difficulties that I had in deciding to transition at age 50. So I think when I think about universal healthcare and single payer healthcare, it always go back to this matter of choice. So when your healthcare is tied to your employers, your employment, in my case, it was kind of unique because I decided to transition after I became unemployed, kind of ironically. But there was a reason for that as well, because I was afraid that I couldn't transition while I was being employed at my old profession because of discrimination I would face, and I may lose my job, frankly. So being unemployed actually opened up for me the opportunity and the possibility of transitioning. So I took that opportunity at age 50. But thinking about other people who may want to transition, but who may not really like their job. But under the current circumstance, though, if you want to keep your healthcare, insurance, there's no way you can leave, your work. And that's a huge thing for me when I think about current situation of healthcare in this country. And I guess it goes for not only LGBTQ plus people, but I think all of us, so your insurance, your healthcare is tied to your employment. So it really does not give you a lot of choice, in terms of you are stuck, if you want to keep health insurance for yourself, for your family. In my case, I'm a single mother. I have a daughter. So, for the longest time, it was really not an option to leave my employment, because I really had to keep insurance for myself and for my daughter. So that's one thing. And another thing, going forward, so I think about, since, as I said, I started transitioning the end of July. So it's kind of like July, August, well, technically August, September, October, November, December. So it's like 5 months. So I'm still new to this. I look pretty, pretty ambiguous still. So, I'm not really worried at this stage, but like, okay, so when I fully transition though, I do worry about like going into like OB-GYN for a checkup, or, if I have some issues. And, it's like, I really think about that a lot. And if I face discrimination, if I can find a provider that's understanding of issues that we may face as a transgender people. So, but again, under the current system, even if you have health insurance, usually, you do really not have a choice of, what providers, who your providers are. You pretty much have to, go to someone on the list. It's not like you can walk in anywhere and get healthcare. So that's another issue for me about, in terms of choice. I think, we should be able to choose our own provider. And I think, so today I saw statistics, 50% of transgender people have faced discrimination at the place of healthcare. So that's a huge number. So it's really, really critical for us, LGBTQ plus people who, to have healthcare providers who are understanding of our situations and who are really, who do not discriminate because of our sexual orientation or gender identity. So that's second thing. And the third thing I wanted to talk about, and this is actually personally very, very huge for me, and I think Daniel actually touched on this issue as well. So it's an issue of mental health. So frankly, I mean, I've gone through my life, having a lot of issues with mental health, and I've dealt with that for the most part on my own. And it's not only about, I don't think it's only about my gender identity issues, but it's a matter, it's a fact that, again, the statistics that I saw today while I was researching, and I was actually kind of very, very shocked by this number because I didn't know the number was so high. So among transgender population, the people who have attempted suicide, who have had suicide attempt at least once in their lifetime, is 4 times larger than the non-transgender population. That's a huge number. And I can see, as a first-hand experience, I can see why. I do struggle with that as well, to be very honest with you, because of the years of, I think, because of years of living my life as, not totally myself, and experiencing, this feeling of alienation, and also, as if I'm faking it and I'm deceiving everyone around me. And that really, has taken a very huge toll on my mental health. So, I mean, under the current healthcare, and actually, throughout the years, even when I had healthcare under my employer, I always had to think, twice, 3 times about getting mental health care because of the cost, frankly, because I mean, let's face it, having insurance, who said that? Okay, but last weekend I was attending an event promoting AB1400, and somebody said, insurance is not healthcare. It's not an access to healthcare, because even if you have healthcare in this country right now, cost is really, frankly, prohibitive. You cannot afford most things. That's the ridiculous part. You pay hundreds of dollars monthly, and you still do not, you can't afford healthcare. And I think, for me, mental health, I always put that on the back burner, which, shouldn't be, but I did because I just couldn't afford it. I could never afford that. So anyway, so having something like AB1400, universal single payer system of healthcare can be, it's huge for people. Again, as Daniel said, it's a matter of life or death situation. So, we really have to pass, something like AB1400 at state level, and eventually we should have Medicare for all at the national level. So thank you very much.
Thank you. Yeah, and I think you bring up a really great point also in just every little barrier. It doesn't seem like, oh, if I don't have access to mental health care, like, each little barrier stacks up with everyone's different intersections. And I think, having a queer identity, it impacts that. And access to mental health often is seen as a privilege. And, as someone who is currently on Medi-Cal, it's hard finding someone just because it's constant, and it's almost easier to just stop advocating for yourself because you got life to live too. So I think those are really, really good points. And also the cost of medications, that's really impacting the LGBTQIA community, just because it is like for PrEP, it is $2,000 a month. And, feeling safe at your provider. Can you get a full woman exam at the OBGYN? How can we find access to doctors that we know we'll feel comfortable with when we have to cater to what our insurance wants us to go to? And AB 1400 would make it more accessible for people to choose which doctor they want to go to. Exactly. Health insurance is a luxury in this company. In this country. Ooh, that was a Freudian slip.
An accurate
one. Jigs. I have a question. Have we thought about putting together in the meantime, while we don't have the universal, while we have, and I guess it would have to be insurance based, insurance by insurance, but we could probably just list provider and then what for insurance those providers take. But as you were talking, I was thinking that even if somebody takes our insurance and is willing to treat, and work us through our transition, that doesn't mean that they're the best suited, that they treat people well and things like that. So what has anybody thought about maybe putting together a guide of, kind of like word of mouth? We know we've been through these providers, we would recommend them. And then, somebody can go through their insurance list and then you are correct. Absolutely. But so we could go through the provider list and then see if those providers are on our insurance list when we're dealing with that, or vice versa. But kind of like, I don't know, like a trans Yelp for providers that's not like corporate. It would just be like a list or a guide that we could put, and it wouldn't be a trash talking thing. We wouldn't put anybody bad up there. We would just known goods, something like that.
Can I jump in here, C? Thanks. First of all, I just wanted to thank you, Tsukuru, for sharing your story. I am so touched and moved by everyone on here who is sharing. So I just want to thank you so much. And just so many different points that you've brought up that definitely, are worthy of addressing. And Daniel, that is such a great idea that you just said. One of the things that I wanted to say about CalCare is written into the bill is there's a cultural competency piece, and it's very specifically written into the bill. And this is the first time this is the 7th attempt at getting a single payer bill here in California. And this bill is really special for 2 reasons. Number one, it closes the HMO ACO loopholes, which I know that sounds really wonky, but that is the type of loophole that would allow the caste system to continue and just and continue the worst aspects of the current health insurance system, of unequal tiered care, payment schemes that disincentivize patient care while increasing the opportunity for financial fraud. And the other thing that makes this bill, AB 1400, and by the way, the federal bill, Pramila Jayapal's bill, HR 1976, also closes that loophole. So that's really important to know. I know I'm like off on a tangent, but I'll bring it back, but just go with me for a second. Right now, the alarm bells are ringing about how they are basically defunding and dismantling Medicare, and they're doing it through this tricky thing of Medicare Advantage. And people think Medicare Advantage is Medicare. It is not. It is private healthcare that uses the name Medicare. Okay, the reason why this is happening right now is because there was a loophole in the Affordable Care Act. And it said something, I don't have it in front of me, so don't quote me, but it basically was like, and Medicare has the right to experiment with these insurance forms, like something. That loophole was written for Medicare Advantage to do exactly what it's doing right now. So this is why I'm bringing up this loophole. This is very important to pay attention to, because these loopholes is what, you know, just takes an amazing, what would be an amazing bill and turns it into in name only, right? So if you see a single payer bill that has this HMO ACO loophole, it's not exactly single payer. So, so I'm just drawing an analogy there. But the other thing that makes AB 1400 CalCare so special is what I was mentioning earlier, which kind of relates to what Daniel, you were talking about, and Tsukuru that you were talking about, is having culturally competent care. And this, you know, is, you know, a broad thing from race to gender identification, but it's calling this out. And it's bringing this in. And so, so I just wanted to highlight that as you were talking about that and talking about, you know, we need more providers who are culturally competent in this area. And, you know, when the other thing about this bill, which Tsukuru mentioned, you know, right now, you think that you can pick your own provider, go ahead and try. Out of network, in network, I mean, all of this stuff. So all of these networks are gone. So Daniel, if under CalCare, if you went to a provider and you feel like you weren't connecting, you can go to another one or another one. You can keep going. There's no one to be like, well, let's check with your insurance. Oh, nope, that's out of network. So you're stuck with that one unless you want to pay $150 a visit. So I feel like that true freedom of choice combined with culturally competent care, and then we're going to bring in Daniel's guide, you know, we're really creating something so inclusive and beautiful for all of us. So I just wanted to share that. And I, you know, I was moved to share that based on what you guys were sharing. So thank you so much, but I'm going to close my mouth now and turn it back over to C.
Before I see a couple questions in the chat, before we do hop into that, I did do a quick search, and there is a website called outcarehealth.org. I'll post the link in the chat, and you can look up where you live that has LGBTQ friendly providers, hopefully. I haven't used it yet, so I don't know whether it stacks up or not, but also there are a lot of, in my experience, I go to the Trans Lounge in the LA LGBT Center, and they've been a really great place to like get information and insecure about trans non-binary things. So if that helps anybody, I hope. But yes, let's get to questions. So the first one I see is, would any of the panelists like to comment on the provision of CalCare AB1400 numbers for culturally competent care, and how that would apply to the trans LGBTQ plus community? Panelists, do you have anything you would like to add? Erica hit a lot of the points.
Well, I know that, like, and I don't know if there's more that you'd like to add, but like, I know that Tsukuru, I was really touched when you were saying how it, you know, like, I need to have gynecological care. Like, how do I know that I'm with somebody that, you know? And so I, you know, if there are other, you know, other concerns that you want to share, so that those of us who are not familiar with these struggles, you know, you can help put it, you know, out there for us, or not, you know, but that's one thing that, you know, might be helpful to hear more about.
Yeah, I mean, I just I don't know if I can contribute like any new points, but like yeah, so again, like that issue about walking into quote unquote women's clinic really kind of terrified me and still terrifies me. Because again, like when I fully transition and I kind of look like a man on the outside, I guess, you know, because yeah, I mean, it's kind of weird way for me to put it, but you know, I guess like that's kind of like how people look at me from outside. But I still have female organs in my body. So naturally, I may have issues, you know, who knows? I may get cancer, you know, God forbid, whatever, right? So there comes a time I need to go in to OB/GYN. And I just kind of imagine myself, you know, like, okay, so, you know, here it is, like a person who looks like a man walking into a women's clinic, and everyone will stare at me. And that terrifies me. And I can kind of imagine, I can fully imagine that prevents, you know, someone from getting care actually that they need. And that may be life-threatening, that hesitation and not walking into OB/GYN. So, I mean, and, you know, when I talk about this issue, you know, people point out, oh, you know, there are trans-friendly doctors. Yeah, okay, I know that, but so again, do I have a choice to go there? Is the issue. I probably won't, I mean, I don't know, who knows? Depending on my insurance, the kind of insurance that I have, I may not have access to that doctor. So yeah, it's just really a huge issue for me. And also, actually, okay, so before I came out as a trans pansexual person, I was, you know, I identified as lesbian for 10 years, 10 plus years. So I mean, sexual health, that's a huge issue too. You know, like when you are seeing your doctor, can you comfortably talk about these things? Can you comfortably disclose even the fact that, yes, I'm a lesbian? You know, it's, yeah. Yeah, it's just, you know, so again, it's about a choice, but, and yeah, what you know, brought up, Erica, you know, culturally sensitive, culturally competent care. Yeah, I think it'll be a huge thing for LGBTQ plus people. So
Thank you so much, Tsukuru. Anybody else? Daniel, I saw your hand. Oh, and then I see Chengson after. Daniel?
Sure. So what I can say is that it is absolutely terrifying to this day. There's a gentleman that I follow who has transitioned over a decade ago, had, you know, all of the surgeries that he wished to have. And he still posts videos all the time about it. He's like, oh, I've got to go to the OBGYN, I'm terrified. And it gets better once you do find a provider that you know, but especially that first time, it is terrifying. And even once you build up a good rapport with, you know, say your provider and maybe even the front desk staff, like Tsukuru mentioned, the other women waiting, like, why is this guy here? And then also having a provider, even again, then once you get through all of those layers, full disclosure for myself, I've had all of my internal feminine organs removed, but you still have to go in for checkups because there are still things that can happen. But if a provider doesn't know what they're looking for or responds weird, I mean, they should already know looking at you, something gonna be weird inside. But like, you know, if they aren't trained in what to expect and what to look for because things are a little different and you've had, you know, they should be familiar because it's still basically a hysterectomy at that point. But again, it's a hysterectomy in a male, the situations are different. You're not on estrogen as a typical somebody who has had a hysterectomy as a female would. So there's a lot of variance and differences that if they haven't been through this, there's a lot of hiccups, hurdles, things that can be missed. And, you know, just the basic not even being able to build up the courage to go in and seek that treatment. So knowing that there's a protection put in that all of these providers have to have some type of training and instruction and cultural, like the competency. And then also, again, the freedom to go wherever you want, because that's one of the things that frustrates me the most with the disinformation against Medicare for All is that it will remove choice and that it will make providers not have to treat you better if you could go anywhere. And I was like, no, that's backwards. If you can go next door, that provider has to work harder to keep you. They have to make sure they treat you well. They'll have to stop double booking, stop overlapping, make sure you get more than 5 minutes with somebody who knows what the heck is going on. So the cultural competency loop, having that piece in there, not the loophole, but having that piece in there is very important. And then, yeah, just the expansion of freedom and choice to not have to take abuse or mistreatment or inadequate treatments, even if they're not being bad to you, but they just don't know. The freedom to be able to go somewhere else is massively important, to not be restricted by your insurance limitations. And then also just distance-wise, it's awesome that you have the LA Trans Center there to go to, but here in Ventura County and in other more rural areas, there isn't that resource to go to. But if we and I was blown away that the Santa Paula Pride Clinic is actually through Ventura County healthcare system. So it's not a private center, it's not a Kaiser or anything like that. And so those kinds of places can be built out to be even more of a resource rather than just a provider for locations that might not have a community resource center. So we can turn that provider into much more than just a place to go get your individual care, but a place to, where should I go for my surgeries or referrals for plastic surgeons, OBGYNs, and things like that. So.
Awesome. Yeah, let's take a question. Go ahead.
Eric has jumped off for a bit.
From who?
Okay.
Which? There's two people with questions.
Let's go with Cheng Sim.
Cheng Sim, okay.
First I want to thank all the panelists for sharing their experiences and knowledge and insights with folks like me who are not part of the trans community. It's been very informative. And I just wanted to relate it to the question about cultural competency, the provisions for cultural competency in CalCare. One of the great things about the CalCare AB1400 is that the bill actually provides, it doesn't just lay out the need for cultural competency in the delivery of healthcare. It also provides funding, right? It actually prioritizes funding to address all kinds of inequity, like healthcare inequities. And whenever people talk about healthcare inequity, broadly speaking, they've tended to focus on racial and geographical and economic inequity. And I think what the trans community brings is to expand and deepen our understanding of what inequity is, to include the kind of inequities that you guys have, talked about. So I guess what I'm so I guess CalCare is actually really cool, apart from the cultural competency angle, that it actually prioritizes funding to address those inequities. So, and I think what would be fantastic is if the organizations like what Daniel mentioned are part of the, even when CalCare is passed and it becomes, the law in California, it would be fantastic if the vision that Daniel pointed out earlier, that the LGBTQ organizations are involved in the shaping of, the policy. It can influence policy so that inequity, healthcare inequity in California, will encompass like inequities for, the trans community as well. And I just wanted to point that out because a lot of people don't realize that CalCare, actually funds what policy it lays out. It actually, the bill actually has prioritizes funding. It doesn't just lay out the policy, but it says that money is going to go to address all sorts of inequities. And I wonder if any panelists want to address that more beyond the culturally competency angle, but the funding angle of addressing inequities as it applies to the trans community.
Well, if I'm not seeing anybody hop on that, but I do want to say too, and thank you, Chungsim, that's a great point. They actually prioritize funding for culturally competent care. So very important. Thank you so much. I also, listening to what you were talking about, Daniel, another thing, right now, doctors are spending thousands and thousands of hours on the phone with insurance companies. And so AB 1400 does away with that because there won't be any more insurance companies. And so what that will allow also to happen, obviously not just doctors, but nurses, all kinds of healthcare practitioners, they will have more time perhaps to take the time to get culturally competent care training in different areas. Also, Daniel, you mentioned, I want to be with somebody that's going to spend more than 5 minutes with me. Again, AB 1400 allows healthcare providers to spend more time, because they're not on the phone, have to be on the phone, calling and fighting for approval of something they already know their patient needs, and somebody with no healthcare expertise on this patient is telling this doctor, no, they don't need it. And then they're in that fight. But, with the way that the medical industrial complex works, like, hospitals, they are making a profit off of people's illnesses, sufferings, needed procedures. And so, they're telling nurses, you can only spend this much time with a patient. And so basically the big picture is, because CalCare removes the profit incentive, our health, right now we have a health insurance system. We don't have a health care system. And we talked about this earlier. Health insurance is not health care. Health insurance is a product. It is a product that is sold. Would you like the gold one or the platinum one? You can pay a little bit more for, or a little bit less for the silver one. These are products. And so once the profit is taken out, you have, healthcare based on the patient's need. And so I just wanted to, I see, Paul, that you also have your hand raised, but I just wanted to touch on that. But go ahead, Paul.
Yes, my question is, and this is something that I've noticed hasn't been addressed yet, at least in many of the circles we are in, but what about people in the state prisons? Are they going to get CalCare? Anybody want to chime in?
James, I've been talking a lot. You take it.
Yeah, the short answer is yes. Basically, it'll be one state-funded system. Prisoner, not prisoner, employed, unemployed, tied to a job. Everyone gets covered. So that's kind of where we are. What I did want to discuss, especially with our brethren and sisterin, is the issue of discrimination. There's a lot of talk about the tyranny of government, and it really is the tyranny of insurance companies and the tyranny of employers. We've had a lot of difficulty with employers saying, I will not support an insurance company that goes against my religious beliefs. None of my employees can get reproductive care, and I fear that a lot of their personal beliefs, I mean, basically in this country, anyone can claim a religious belief or closely held belief and use it to discriminate. So I'm curious to know what forms of discrimination you've seen, particularly in the non-binary community, because my view is that you really are the outcast of the outcast of the outcast of the outcast, and that is completely wrong. CalCare will fix that. You're not going to get another job or find another health insurance company. So if anyone wants to chime in about the types of discrimination you've heard about amongst employers.
I don't personally know of any because I am unemployed. So the privilege of that, and also though, don't forget about like the race and privilege, because I am partnered. So thankfully I have that privilege. Daniel, I see you're unmuted, and then yeah.
I was just going to kind of echo what you said, See, that I personally have been fortunate that I haven't experienced that. And I think part of that is where we are here in California, that our healthcare system and our society, as backwards as some of our country is rolling, we still have things really, really good here. It still needs to get better, and there's still a lot of ways we can improve. But I know for a fact that if I was still living in Maryland in 2015, when I started transitioning, that I probably wouldn't have, because there were employers and things more common on the books that say, we won't take an insurance that supports these, these procedures, or, at the time they were considering them and cosmetic and unnecessary alterations and things like that. So until, and this was kind of crazy, that until it was listed in the psych manual as a mental illness, that was when insurance companies were forced to start accepting at least the mental health care. And then it was a good slippery slope to where it just continued opening more and more doors, because once we were in with the healthcare and the mental health, and the mental health providers were saying they need the next steps, we need to, start transition and things like that. But so until, it was weird, because my therapist even explained it. He was like, unfortunately, I have to list you as having a medical or a mental disability or impairment or a condition. Mm-hmm. But the benefit of that is now you get access to all this wonderful care. And so I was like, whatever, hook it up. But, there's some people who aren't going to want to have that stigma, or we shouldn't have to have a negative mental health stigma to qualify for healthcare. And so I think that was one of the ways, that was one of the first barriers that we had to jump over. And then once the American Medical Association put it in the mental health manual, it forced insurers to at least start accepting some things. So I think that is one way that we can see where legislation and different things can have a positive force. And like I said, unfortunately, we had to be listed as a stigma, but then it gave us access to some care, and we're gonna work to change all of that. But I would say that a lot of those loopholes have been started to be closed whether it be because you are, identifying as a different thing. I was actually blown away at the Supreme Court decision where Justice Gorsuch said, you couldn't mistreat a man for dating a man in this workplace. Well, then you can't mistreat this man for wearing a dress and dating a woman. And I was like, when the conservatives are accidentally based, I'll take it. So I think that it still exists. We don't hear about it a lot in California because I don't think it's as common. And then again, why we need to, make sure that this gets expanded out nationally, because especially in the rural Southeast, they do not have, these protections or luxuries at all, where they use a lot of those loopholes to get around. So I would say that we're fortunate here, but it definitely still exists.
Thank you, Daniel. And that is the intention of CalCare. It is to get it. It's not just about California, right? And you mentioned this earlier. In Canada, their single payer system started in one province, Saskatchewan, and then it took, the rest of the country. And so that is the intention. It gets done here, and then it, goes for the larger healthcare justice fight, Medicare for all nationally. But C, I'm going to turn it back to you.
Beautiful, thank you. I wanted to introduce another panelist who joined us. Her name is Jamie. I would like, Jamie, would you like to introduce yourself or hop on in this conversation? No pressure if you're not feeling this topic, there's always another one.
No, my name is Jamie Penn. I use she, her pronouns. I've done a bit of organizing and activism around some healthcare initiatives. I'm often involved with the California Nurses Association. So I have lots of input. I can second a lot of what Daniel has said, and that, having to be diagnosed as a mental health disorder is the door. It's literally the start square on the monopoly board to be able to access trans healthcare. Moving on from there, it's a lot of being patient and being very insistent, and unfortunately, a lot of advocating for yourself, putting the ball in the court, on the side of the court of the individual, which isn't often fair, but that's most often how things get accomplished. Even my experience, I've used the LGBT Center almost exclusively throughout my transition. And they have a coordinator, they have some staff that are, more in tune with trans healthcare, but even still, there's just still so much of just not knowing and going with what was taught, I suppose, in medical school, all through my beginning of my transition. My what I refer to as my dead name, not my chosen name, remained on my chart for insurance purposes. It remains on your chart until you get it changed legally. You have to see it on your chart every time you interact with your medical care provider. And even after that, you still have often your pronouns are written in as part of your name. The very systems with which they track you aren't designed to keep track of the things that are very important to being able to provide good medical care. So there's still a lot of work to be done. But I thank you for inviting me, and I'll sit and listen and try to add what I can where I see an ability to.
Thank you so much, Jamie, for being here with us and sharing that. Again, I think, well, I'm so touched by everything that I'm hearing here, and by you all sharing, it's educating those of us who are not dealing with these issues, and just helps us, bond and fight for this human right for all of us. So thank you so much. I'm just, I don't know, I feel like I'm blushing that y'all are here. So you know, I've heard this come up a couple times. So mental health care, and how important that is to the community. And so AB1400 CalCare includes mental health care. It includes, I mean, you name it, it includes it. It includes, you know, chiropractor care, substance recovery care. I mean, and so this is one of the things that I love this bill. You know, it's not just limited to the medical. Our health is, you know, our mental, our emotional. And so this bill, again, you know, it's like, even if you can get your medical care, it's like, you know, now what, paying out of pocket for mental health care, you know, it's just, it's a lot. And, you know, and I'm thinking too about prescription costs, right? Like, so I have to take, it's called Angelique, and it's like a combination of estrogen and progestin, and you know, and that's like $50 a month. And I feel fortunate, like okay, that's kind of like all I have to take, but who like only has to take one thing? So again, another thing, Daniel's laughing. But yeah, but so this is another thing that CalCare does, right? So it's really the whole picture. So I just wanted to, you know, really highlight how important mental health care is, and that this bill provides that. Does anybody want to speak any further on that?
Oh, go ahead. Tsukuru.
Yeah, hi. Actually, it's not about mental health. Okay, what I'm going to say, it has been kind of on my mind, and I was kind of trying to figure out how to say it because I wasn't really sure. But so yeah, funding for cultural competency, you know, that piece really, I actually did not quite know about that. So, you know, having heard that really was like really very educational for me this evening, and thank you so much for bringing that up. So yeah, I think it's really great that CalCare provides funding, you know, for healthcare providers to be educated, and so that they can achieve, you know, cultural competency on their part, because I think it's really important to sort of like raise, you know, the level, I guess, of our healthcare providers across the board. But so, you know, while I was figuring out, you know, how to transition, how to start my transition, I was doing a lot of research. And at the time, I knew that I was going to be unemployed, but I still had a job. But anyway, so, you know, there are like in the marketplace, in healthcare marketplace right now, you know, for-profit marketplace, there are providers who are, you know, kind of like a new kind of providers are popping up to like bank on this opportunity where, you know, people like me are feeling very insecure about traditional healthcare providers. So there's a lot of fear that, you know, as I mentioned before, that maybe like traditional doctors really do not, or I should say mainstream, you know, mainstream healthcare providers do not have knowledge or do not have awareness of, you know, what LGBTQ communities, you know, face as issues and concerns. So there are like new types of for-profit healthcare providers where they are like focused on LGBTQ issues, and they, you know, their team is, you know, consists of LGBTQ people, and they provide like a telehealth services and like kind of hormone replacement, you know, services and stuff like that. So I always had like very ambivalent feeling about this, because a part of me really wanted to get a care, you know, from that kind of for-profit providers, because I felt like they know, you know, what our concerns are, because they are, you know, they're in the community, I guess. But at the same time, you know, them being for profit, and they are, in the business of kind of I don't know, profiting, of from their of our concerns and like worries. So I guess what I wanted to say was, even though, okay, so I do have ambivalent feelings about these like new for-profit healthcare providers popping up. And I do think that it's very important for mainstream healthcare providers to get educated on LGBTQ issues so that we can raise the floor of quality of healthcare services that we get. I think it is great if AB 1400, gives us choice, I guess, to choose these providers as well, who are focused on LGBTQ healthcare issues. Anyway, yeah, I just wanted to, take a stab at it. I don't know if I explained this, well enough, but it's been on my mind. So.
Thank you. Something that I'm also kind of like really vibing with in this conversation is also to kind of bring it back to also to something that Erica said, and also touching on like what Jamie said, is just like, these are issues that like, whether or not you're aware of it, we're all dealing with it at the doctor's office. Like when you mark what gender you are, or if it's just assumed, even like our kids. I have a child and they had a physical exam and it was marked that they were heterosexual. It's like, this kid is 2. Like, why are we pushing a sexuality on them? Can we just give them space to be a kid? So I think this is like, whether or not we're aware of it, I think this is something that like the healthcare industry is othering people, and especially like you make it necessary where you have to legally transition, but it's an extra $500 if you don't qualify for a waiver. So not to, I don't know, I think it's a good opportunity to just be like mindful, especially in my transition. Like I'm not doing a lot of physical stuff just because I know I'm going to get a lot of pushback if I were to start hormones or something. So because I'm already disabled, so I don't want people to be like, how do I treat this like human that's so far off the textbooks, which shouldn't be the case. And I'm hoping with CalCare that would really help and just kind of help find that sweet spot for me. Would anyone else like to share? Yeah, go for it, Jamie.
Yeah, I think that's very interesting because certainly in my experience, most medical care sort of approaches you from a, you should be this for me to treat you. And when you're not that, you get less quality care. And it's odd because very few human beings are alike. And I would just imagine that it would be a better quality of care if you just approached from a, what kind of human being are you? Instead of, this is a human being and these are the variances you have from what a human being should be. And that's just been my experience. I very much have felt like I was getting a great example, actually. Whenever I get my hormones checked with my blood work from the lab results, all of my hormones come back in red because I'm out of the range for male hormones. Because my hormones don't match what a male should be, I'm a woman. And I'm in the female ranges of estrogen and progesterone, and I don't have testosterone, or very, very little. And so all these numbers in my medical chart are red. That's just an example of why the care that I seek or the care that I receive is an othered care, because I don't fit what a human being should be by medical definition.
Yeah, othering, really, it sucks. And I know people don't like go into the medical system and to care for people to make folks feel bad. And I think there's a hesitancy also to like meet us where we're at. And as we were talking earlier, you know, it just creates another little barrier, and they just start adding up to make a wall, to make it a huge hurdle to hop over. Go ahead, Tsukuru.
Yeah. I just so Jamie, thank you so much for actually, you know, in your earlier comment, you brought up about the, you know, dead name. Yeah, so I have a Kaiser, and I have to be honest, for the most part, Kaiser has been really good actually to me in my process of transition. So I have a very little complaint as far as like you know, nurses and people concerned, but so they have this weird thing that who, you know, people who directly deal with me, such as nurses that I go in and get my weekly shot of testosterone, they call me Tsukuru, that because that's on their chart. But when I check in at the front desk, my dead name comes up always. It's probably, you know, as Jamie pointed out, it's probably about something about the insurance and, you know, having to have a legal name on there. So, and I guess like my gender too, I think says probably female. So I get called Miss all the time at the front desk. Okay, so to cisgender people, it's nothing. I know it's nothing. To us, it hurts. So every time weekly when I go in there, and when I get called by my dead name and called Miss, it hurts. It's just a stab in my heart. But you know, I kind of learned to deal with that. You know, I kind of tell myself that, yeah, okay, this is how it is. So I just live with that. But yeah, I mean, these little things add up though. You know, talk about mental health issues, these little stresses, pain adds up. So I just wanted to, you know, point that out. And thank you, Jamie, for bringing up.
There was a question earlier I saw.
You know, before you move to a
go ahead.
question, C, can I just respond to Tsukuru? Again, everything that is being shared is precious. See what you shared about your 2-year-old, and can't we just have a space for them to be kids? I mean, all of this is just really, you know, it's just really precious information. And so, and I think like it's really, this is the healthcare justice, right? Like we're moving from like healthcare to healthcare justice. And yeah, there's so much that needs to be done. And I just want to say, I really hear you, Tsukuru, and how much that hurts. And you know, there is so much on the healthcare justice side that has to be done. And, you know, CalCare really, where is it, may not go all the way there, but in providing funding for cultural competency, in providing medical and mental and all healthcare for all, it is, you know, significantly moves us along the path there. Also, you know, when you were talking, Tsukuru, about the these for-profit, you know, health centers that are really working with the LGBTQ plus community, you know, again, it just strikes me like, right, so it's right back to capitalism. You get amazing care if you can afford it in this country. But if you can't, you're just left to put together what you can. You know, medical bankruptcy exists in this country and not in other countries. And then, you know, that's another, you know, place where people are victimized in this system. going, losing their homes, losing their finances, not being able to afford. So, CalCare, ends that part of it. So anyway, thank you so much for sharing. I do see Jeffrey has his hand raised. Jeffrey?
Yeah, I'm here in Sacramento, and I talk with the legislators repeatedly. I remind them that their bills have unintentional consequences. But I'm also going to offer right now the reminder that we hold up Kaiser as the 5-star of California in the way of hospital insurance. And yet, Kaiser, you have to do individual case by case for replacing medical equipment because they have a $2,000 limit. That's what insurance provides, even with Kaiser. So for those people that are disabled that depend upon an electric wheelchair, that is a $10,000+ item. So it is raising even there. And this is why we are trying to get in California the policy to be California saying everyone in, no one out, because insurance companies put limits and deny service. So we need to get them out of the equation. And that's what we're working for here and why we are doing this heavy lift. And LA's done a profound effort in trying to get that message across. We need to get more educators. I talked with my local assemblyman, Kevin McCarty, and I've been with you for 562. I've been with you on this. Yeah, but what more can you do to convince your fellow assemblymen the understanding of why this needs to happen? Well, I'm just one vote. Got him to go a little further and got him to get to, so he was going back to check with Ashkara, but maybe more can be done. But that's why we talk to our legislators, get them to move when it's an important subject matter. And that will be my comment for tonight. And I will go back to being quiet and listening. Thank you.
Oh my gosh, Jeffrey, thank you so much for sharing. I really appreciate that. And we will talk a little bit more toward the end about action steps that can be taken, but you are so right on calling your assembly member, telling them to support AB 1400, getting legislative visits with your assembly members to support AB 1400. CNA is basically leading the way on this, but Paul can drop our toolkit in the chat, which also includes the CNA toolkit. So it's kind of one-stop shopping for actions you can take. It's a bit.ly HCA toolkit, but Paul will drop the actual, the bit.ly in the Zoom chat and the bit.ly in the Facebook chat. But see.
Yeah, I found the question. It was asking whether or not we know how many districts or how many people have signed on, if anyone knows about that. How many cities or counties passed a resolution to support CalCare?
Chang Sim might actually know how many have passed resolutions. I believe the bill has 16 co-sponsors at this time. And then you have your author, Ashkara, and your co-authors, co-principal authors, Miguel Santiago and Alex Lee. But I'm not sure how many cities or counties have passed a resolution. Cheng-Sin, do you happen to know? I know she's kind of multitasking, so she may or may not hear the question. But we are very proud that Los Angeles, oh, there she is. I'm gonna.
I haven't kept track exactly, but the ones I know about are here in Los Angeles, And then Santa Barbara, actually Santa Barbara was the earliest to pass a resolution for CalCare. And San Jose recently, and then Sacramento. Those are the 4 I know about. I know that there are efforts in other cities as well. Santa Monica doesn't do official resolutions, but apparently they have sent or are sending a letter to the state legislature saying that the city supports CalCare. So it's not an official resolution, but it's a support of the bill. Other people may know about other cities, but those are the 4 that I'm aware have passed resolutions.
Thank you, Chang-Sim.
And then Erica, Paul posted on the chat a question from Facebook. Some people and legislators seem to think that when AB 1400 is signed into law, a new single payer system will be rolled out the next day. They justify not supporting the bill because they think everything must be worked out completely, especially financing, before the bill is passed. I know that's not the case. Could someone talk about that? Could someone talk about what will happen right off the bat when the bill is signed?
Yeah, I can talk a little bit about that. And I don't know if James and then Chang-Sim want to talk a little bit about that, but thank you, Chris. Appreciate you being out there in Facebook land and sending in this important point. This is a policy bill. And like every other policy bill, you pass the policy and then there'll be a financing bill. So these are the games that the legislators are playing, where they can say, I'm with you and I really support this, but you know, how are we going to pay for it? And no other policy bill that our California legislators have passed have they asked that question or get stuck on that question. They pass the policy bill. This is the beginning step. We pass the policy bill. Then we will have the financing bill that then we'll have to get 2/3 majority. We can't get to the financing bill unless we pass the policy bill. When we pass the policy bill, it unlocks the ability to send in an application to the Department of Health and Human Services to allow our state to use funds for, you know, Medicaid, CHIP, and other things like that to be rolled into the single payer public financing part of CalCare. But the way that application works is you have to pass a bill first. So we have to pass this bill first. Then the application goes in, which Ash Kara, Assemblymember Kara, who is the author of this bill, has met with the deputy underneath the Secretary of Health and Human Services, Xavier Becerra, and has pretty much gotten like, yeah, we're on board to get this application through. If you guys fill out the application and attach the bill that you've passed, basically. So we have to pass this bill first. So it is a process. It's not that in passing this bill tomorrow, it's implemented. We have to pass the policy bill, then we pass the financing bill. And part of this policy bill says the program will not be rolled out until, I think it's the state secretary of health, I don't know exactly, but signs off and says, yes, there's enough money in the CalCare Trust, let's go. The California nurses wrote this bill. Jamie, I know you mentioned earlier, you work a lot with CNA. You know, they are, oh, what was that, Jamie? You're muted.
A little, I wouldn't say
a little. Okay, you worked. Anyway, CNA, I mean, you know, from our experiences, there's so much thought that has been put in this bill. Like, you know, in one of the 7 principles, a just transition, of course, you know, their labor, they're thinking about, we have to take care of all those working in the insurance industry. We see you, we're prioritizing a just transition. We're going to get you trained. We're going to get you jobs. You know, kind of like when you look at the Green New Deal, how it's like they're like, okay, those working in coal, we're going to get you high quality paying jobs that are, you know, clean energy. Same thing here with the nurses. And so, but back to your point, Chris, it's a very thoughtful bill. And so even to the point of like making sure the money is there before, you know, it's implemented. So, but if anybody else, Chung Sim or James, you want to weigh in on this?
Permission to speak, ma'am. So what I will say is that when Medicare was passed into law, it took 6 months. I've heard things from 6 months to a year after AB1400 is implemented, all the way through 5 to 10 years, basically, if we go at a snail's pace and let things crack. So after we get the waiver and the bill is passed, we need to appoint the board. They need to start the negotiations with the pharmaceutical companies and with hospitals and providers. That includes speaking with all the professional organisations, say, you know, your pulmonary specialists and whatnot in every medical field. That's going to be some time, but it is a process, and also determining what global budgets will exist for hospitals and what fee-for-service budgets will be allowed for individual service providers. So it's not going to be tomorrow, but I don't want people to think I'm going to be on Medicare by the time this thing actually gets implemented. The beauty of this is that we have so much of the infrastructure in place, and the hospitals obviously don't want it. They don't want the veil pulled up from what they're doing. They basically say, we need to charge 7 to 10 times the cost price to pay for those horrible Medi-Cal people. And we know that there's only a slight bump in their cost base, and they use it as an excuse to charge commercial insurance customers the actual premium. Drugs, you know, for some generic drugs, we pay about 10 times what the rest of the developed world pays. There is a system called Best Price, which basically all the other health departments in the developed world use. So look at average prices. What I tell people is look at the COVID vaccine. The typical cost is about $20. Now imagine if the health insurers were allowed to set prices. There'd be a sliding scale and there'd be waivers, and people with bad insurance will be paying $200 and the Medi-Cal people will be getting it for nothing. That's all going to go. It's an administrative nightmare. We also know that when our governments negotiate with pharmaceutical companies, they're basically arguing we need these mega profits to develop new drugs. That's another story, because we pay for a lot of that foundational research through the NIH and other government grants. They're typically allowed 10 years to recoup the cost of research and development. Typically what we see is that they recoup those costs in about 2 years. So they have 8 years of charging whatever they want before they flip over into generic status, whereby the health insurance just say, oh, these commonly used drugs, we'll just double the price tomorrow because our shareholders asked for it. So understand that there are a lot of steps involved, but don't let it sound more daunting than it actually is. The only people who will lose out are the health insurance companies and the hospital complex. We got to keep fighting for this. Thank you so much.
Oh my gosh, James, yes, thank you. I really appreciate you stepping in. So I want to reiterate what he said. Although if CalCare passed on Monday, it doesn't mean we'd have single payer system on Tuesday because there is, more process to go through. But if we passed Medicare, it took 1 year from the time it was passed to the time it was implemented, only 1 year. So again, I don't want to make it sound like this is an 80-year process, but I also want to say it is not an excuse for legislators to not pass this policy bill. And, no other policy bill are they demanding, financial information and they have to understand every nook and cranny, and they need to pass this bill. So thanks.
I also had a quick question too, just because a large LGBTQIA folks are overrepresented in, I think, the unhoused population as well as in the foster care. Could you please talk about how AB 1400 would help these folks in their situations and getting access?
Okay, can I speak to that? Can I speak to that? Yeah, okay. One of the biggest problems we have in this country is that all these government departments exist in silos. So we're going to have to start looking at more interaction and more cooperation. So with regard to housing, Houston's a prime example. They've basically coordinated all the services, and they said if you've got a roof over your head, access to healthcare services, a lot of the other things start falling into place, your employment and whatnot. So we need to be wary that our expertise is going to be only in the healthcare area. But the problem is that a lot of the housing people will say, okay, I have an unhoused LGBTQI person who has medical issues and we don't know where to go. Now they'll say, we'll call up go online, where's our local CalCare clinic? And they actually have the access. They don't have to deal with fractured programs which are on or off or work certain times of the year, or how do we deal with private providers. They basically have access to the entire library of services. And it will get rid of a lot of the inefficiency, which the service providers love because they use that to justify their high prices. And that's kind of, it's really about coordinating all the social services. So we are going to have a hand in that. One thing, just backpedaling a bit, in terms of prices, we're going to start, everything in the hospital, well, I don't know if you know this, is based on Medicare prices. So that's going to be our starting point. We're not going to be reinventing the wheel. Medi-Cal prices, which are typically insulting to physicians and physicians' assistants and whatnot, that'll all be abolished. They're going to be paid, they're not going to be paid $15 an hour to look at a patient. So anyway, I'm going to hand over the mic before I keep talking, but yeah, the housing people love us because they're actually going to have somewhere to go. And if we say deploy a team and we're looking at, say, healthcare for homeless people, we're going to say, okay, we can take care of the medical side of things, but the homeless associations will be able to look at provisional housing and whatever other services that they need. And that doesn't exist now. Thank you so much.
Thank you. Jamie, I see your hand. Go ahead.
And now you're speaking on something that's near and dear to my heart. I do a lot of activism for our unhoused community here in Los Angeles, and there is an inextricable link between being unhoused and having mental health issues. And not often enough do people really acknowledge the fact that being unhoused can cause and or exacerbate mental health issues. And just hearing these things and these resources and being, allocated by, mental health providers, medical health providers, just, I can't help but imagine, like, knowing houselessness can cause and exacerbate these issues. why is it not yet possible for like a general care provider to write a prescription for housing? Why can't we go, okay, the thing that you need in order to get better, in order to stabilize, in order to start the process, you know, whether it's LGBTQIA individual or really anyone, is housing. Why can't we prescribe you housing? So I hear this conversation, and I know where my heart lies, and I can only hope that that's the direction that we are headed.
Robert, I see your hand. Go ahead.
I'm gonna have to agree with Jamie on this one, because I also help out the unhoused population here in Sacramento, and one of the most expensive things for healthcare costs is emergency, and a lot of unhoused people go for emergency care. So if they had a place to stay, they may not have to go to emergency rooms so often, which would be cheaper for everybody.
Yeah, emergency care is really expensive, and I really appreciate you bringing that up, Robert. Yeah, preventative care is the best kind of care, honestly. I know I talk about this all the time, but preventative care, and we had talked about this earlier, you know, those little boundaries, they make people wait longer, and then they do go to emergency, and you're not going to get the best care. And even if you get the care you need, preventative care would have made it so you might not have to have, you know, worse outcomes. So preventative care if you can.
Yeah, and so this, we talked about this earlier. Why do a lot of people not get preventative care? A lot of people have insurance and don't get it because their deductibles are high, their copays are high, their premiums are high. They thought this doctor was in network, now it's out of network. They're working a job or two jobs, and now they have to research, and then they're on the, again, we have a health insurance system, not a healthcare system, and CalCare would change that. If you go to our website, hcala.org, and Paul will drop it in both chats, and you go to, or you go to our toolkit, which was dropped earlier, and you start looking, you know, if you read the bill, if you actually read the bill, you will start to see it's not just a healthcare bill. It is a housing bill. It is a jobs bill. You know, the other thing that this bill prioritizes funding for is for the funding of facilities in underfunded areas, underfunded rural and urban communities. What happens when you start building facilities? You start having jobs. What happens when you start having facilities there? You start having restaurants pop up. You know, another thing, Jamie, I was listening to an interview with this gentleman was unhoused, and it was here in Los Angeles, and I just couldn't believe the story he was telling. He had a tent, it was set up in a park where they had created a really beautiful community in the park, you know, so resourceful. But he took in, okay, this unhoused man took in an unhoused woman who was in worse shape, took her into his tent. She was suffering from AIDS, and she could get some AIDS treatment, but she had to take like a bus to the thing. How she could barely get herself basic needs met. How is she going to take like 5 buses to wherever to get treatment? So when CalCare starts, they recognize, you know, we have to have more healthcare, you know, hospitals, clinics within geographical areas where it's easier for people to get to. I mean, these are it's what I'm talking about. The nurses, they are so thoughtful. This bill is so thoughtful. It is a social justice bill. And it is, you know, it is a human rights bill. Housing is a human right. healthcare is a human right. And so these are the things that this bill really puts us on the path to addressing. I mean, imagine right now if everyone had mental health care. What does that do to our unhoused situation, our unhoused brothers and sisters? It's pretty helpful. You know, many are suffering from drug addiction, probably have some mental health issues going on as well. Instead of substance issues being treated as a crime, it's treated as a mental health issue, which is what it is. It takes, instead of throwing people in jail, let's get them health care, let's get them housing. You know, once you have these things, as James was saying, you know, now you can like have employment in place. And so I love this bill. It creates jobs and it addresses so many issues. So Jamie, hand.
I just after hearing you speak, I hopped into one of the PDFs in the toolkit, sort of a fact sheet. And one of the things that really caught my eye was that it states clearly that AB 1400 will lower the per capita spending for healthcare spending. And I think that kind of ties in a lot of the things that we're talking about resource allocation. And, you know, if we can free things up, what else can we do with it? It's just very exciting.
It's very exciting. And since you're there, Jamie, and it's up, if there's anything else that's catching your eye that you want to share, that would be awesome.
Something I also wanted to hop in and say too is what's really encouraging about this bill is that it's not just attacking one issue, it's starting to actually give meaningful community care. Because it doesn't matter how much, you know, mental health resources me as an individual accesses, if my neighbors don't have access to it, then we're not all healing. And I think having CalCare promotes community healing, not just individualistic, which, you know, I think is a different kind of mindset than, you know, typical Americans have. But I think we're getting there, especially with this COVID pandemic. And, you know, yeah.
I love the way that you pointed that out, C. It really is about community. How much more, you know, it's like the more our brothers and sisters are have a living wage, have housing, have mental care, have medical care. You know, now we have, you know, we're in places for so much more innovation. Like we've moved from just like survival to starting to thrive. How much more arts will we see in our lives? How much more care will we give because somebody's not so stressed out and like so desperate to take care of themselves? There's space to be like, I'm okay, you're struggling, how can I, you know, support you? So it really does, I think, move us to be more about a community of care. And then the other thing too, I think this bill does is, see, we were talking earlier is, right now, there are so many fights that people are fighting, just fights, good fights for healthcare things, also in other areas, but I'm just talking about healthcare. So, right, like right now, you'll find an organization fighting for, you know, more mammograms for women. You'll find an organization fighting for, you know, undocumented, you know, need to have health insurance. You'll see organizations fighting for, you know, diabetes treatment and all of this stuff. CalCare takes all of those fights and gets all of that. It's not like CalCare, like, okay, we'll have some more mammograms, but you know what? That diabetes treatment, we're going to need another bill for that. No. What CalCare does is what your doctor and you decide that you need, whether it's, hormone treatment or diabetes treatment, you're going to get the care that you need. You don't have to fight for well, I've got to get this mammogram and I can't get it. So it takes all of these not smaller, but all of these, individual fights and brings them into one big fight to get us all the care that we need, the specific care that the LGBTQ plus community needs, the specific care that other communities need. They're all in this bill because it gives comprehensive care from cradle to grave, long-term care for those who have disabilities, for those who are elderly. So that's the other thing. This bill, when you talk about it, it brings us into community and has us fighting this fight for all of us. Thanks.
Yeah, I agree. We are coming up on 7 o'clock soon. Erica, how much time should we allocate for promoting?
Sure, yeah, we can shift into that. Robert, I see your hand raised, so we'll go to Robert and then let's talk about, action steps that we can take.
Hey, I think we should have the healthcare advocates and the unhoused advocates and the disability rights advocates all join forces because this is one big fight. This is not 3 separate fights.
Yes, that's right, Robert. That's very well said. This is one fight. Environmental justice, it's in here. This is one fight. So I love that. Anybody else have anything to say on that? All right, well said, Robert, to kind of close us out. So, so we have several actions coming up. I'm just going to, give me 1 second.
While you're doing that, Paul posted from the Facebook from James, the COVID pandemic is not just an issue for the United States, it's a global issue. And that's a really interesting point because I remember listening to Democracy Now! And I think it was the World Health Organization that was saying, governments need to start getting healthcare for everybody if we're going to survive pandemics and outbreaks like this. And so that was really affirming hearing that.
Yes. Thank you. See, that gave me enough time to pull up everything I needed to pull up too. So we're a good team here. So we have a letter that you can send to your assembly members. It's, a pre-written letter, but you can edit it if you like or not. And when you put in your your name and your address, what it does is it pulls up your specific assembly member and it addresses the letter to your specific assembly member. And so that is something that we're asking people to do. That is at a bit.ly, bit.ly/CalCare letter, the number 2 ASM, all lowercase. The nurses, CNA, have a petition that can be signed. In fact, the only bit.ly you need to know is actually our toolkit, because we have all of our actions, Feel the Burn, and the CalCare Solidarity. We're just working with a bunch of people. We got all their stuff in our toolkit. So our toolkit is bit.ly, bit.ly/HCALA toolkit, all lowercase. And Paul will drop that bit.ly in the, Paul, don't drop the actual address, actually spell out the bit.ly so that people can take that. Okay, thanks. He'll drop the bit.ly in both chats. But so there's a petition that CNA has. CNA was sending out postcards. They have a template. If that's more of your thing, you can use their template and help send out postcards. I love this one. This is from Betty Dumas Toto at Feel the Burn. She has CalCare Solidarity Photo Pledge. It's super cute. Again, that can be found in our toolkit, but you basically take a selfie and it says, you know, like it'll say, Jamie Penn, CalCares, do you assembly member so-and-so? And it'll be her assembly member's name. And it's a cute little photo with that frame. And then you can post it on social media. I love that one. Very creative. And then we have a caravan, you guys, coming up on January 8th. This is CNA. It's their statewide Calcare Day of Action. There's going to be caravans in Sacramento, in San Francisco. We're doing one here in Los Angeles. And so you can find that, sign up in our toolkit as well. And that's on January 8th. Tsukuru is working closely with us on that. And so basically those are the main actions you can take. You can also feel free to just call your assembly member in our toolkit. We have a link where if you don't know who your assembly member is, you go to this link, type in your information, it'll tell you who your assembly member is, and it'll give you their contact information. You can call your assembly member. You can get a group of 2 or 3 people and request a legislation visit to talk with your assembly member in person. Jamie was talking earlier about how she pulled up the CNA like fact sheet. There's several of them. There's the principles, there's talking points, there's a fact sheet, there's a fact sheet on just finances, there's a fact sheet just on waivers. That gets really wonky. But again, the CNA toolkit is inside our toolkit. There's a link to it. So bit.ly HCALA toolkit is where you can find all of the actions. And I'll go ahead and say my thank yous, and then I'll let you wrap us up, C. But thank you so much for coming on here. Thank you for being who you are. I think when you are who you are, it gives everybody permission to be who they are. I know that I'm feeling inspired to be more my authentic self. So it's contagious in a really awesome way. So thank you so much for that. Thank you for sharing. Everybody out there, if you liked what you heard, we would love to have you join us at HCLA, donate to us at HCLA, and Paul Newman will drop those links. And with that, I will turn it over to C to close us out.
Thank you, Erica, so much. Thank you, Healthcare LA folks, for letting us come on. Thank you, Jamie. Thank you, Tsukuru. Thank you, Daniel. Y'all were amazing. I really appreciate y'all stepping up and sharing your experience. And it's an awkward space sometimes for folks, so I really appreciate, the emotional labor. Yeah, I hope everyone has a safe, responsible holiday, meaningful. I know a lot of Americans are grieving with the COVID pandemic that is still going on. Do what you got to do to keep you and your community safe. Yeah, thank you, everyone. This was really great. Happy, meaningful holidays.
Thank you, C. Thank you, everyone. Good night.
Good night.
Good night.
Thank you so much.